Ada ke? Boleh dah. Boleh dah. A very good morning to all. Selamat pagi tu semua. So untuk sesi CME pada hari ini, saya akan bincangkan sedikit sebanyak tentang penggunaan ubat proton pump inhibitors lah. Ubat ni merupakan sesuatu ubat yang sering di-prescribe sama ada dalam setting inpatient ke ataupun sering diberi sebagai preskripsi outpatient lah. Dan kita hari ini akan cuba mendalami sedikit tentang aspek proton pump inhibitor lah. So let's take some introductions to proton pump inhibitors. This is the mechanism of action where proton pump inhibitor helps us. It basically actually helps to inhibit the secretion of proton ions into the lumen of our gastric to our gastric component, actually to prevent the formation of acid, because acid was formed by hydrogen and chloride. So when there's no hydrogen, the acid HCl cannot be formed. So by then, with less gastric acid secretion, it actually was thought that help to prevent or actually to treat certain conditions where it may actually provoke bleeding or peptic ulcer disease per se. So we have seen a lot of indications of PPI. So these are the known indications which are actually being labeled. First being was Barrett's esophagus, peptic ulcer disease, Zollinger-Ellison disease or syndrome, GERD, GI breathing prophylaxis in long-term NSAID users, as well as functional dyspepsia. So here actually this table actually helps to indicate, okay, how long does a PPI therapy considered appropriate? So in certain conditions, as we say, when long-term PPI therapy was considered appropriate when the patient has a Barrett's esophagus, healing or maintenance of Los Angeles grade C or grade D erosive esophagitis, PPI responsive esophageal eosinophil, idiopathic peptic ulcer disease, Zollinger-Ellison, PPI responsive GERD or non-erosive reflux disease, long-term non-selective NSAID users, we call non-selective NSAID users, at high risk of upper GI complications for long-term COX-2 inhibitor users with prior episode of GI bleeding. That means if you are using celecoxib and you have a previous episode of GI bleeding, then a long-term PPI is considered necessary. Or if you are using NSAIDs like diclofenac, which is long-term, but I don't think that we should give a long-term diclofenac per se, with a high risk of upper GI complications, then you can give PPI per se. Antiplatelet therapy in patients with high risk of upper GI complications like age 65 years old and above, concomitant use of steroids, anticoagulants, or history of peptic ulcer disease, which is fair and square in this case, or steatopera refractory to enzyme replacement therapy in chronic pancreatitis, which is not a very common indication in our medical setting here. Then what justifies for short-term PBI per se, which is a duration of 4 to 12 weeks of courses, would be the healing of Los Angeles grade A and or B erosive esophagitis, eosinophilic esophagitis, Helicobacter pylori eradication, which is used in combination with antibiotics like clarithromycin that we know, stress ulcer prophylaxis in high-risk patients, which will be one of our focus of discussions today, functional dyspepsia, treatment and maintenance of peptic ulcer, prior to endoscopy for acute upper GI bleeding, as well as following endoscopic treatment of a high-risk upper GI ulcer in GI bleed. These are considered 4 to 12 weeks of PPI is considered acceptable, but not beyond that. In which cases where PPI is not appropriate per se, corticosteroid uses without concomitant NSAIDs prevent bleeding for hypertensive gastropathy in cirrhotic patients. This is something that is quite debatable per se, I can say. Acute pancreatitis and stress ulcer prophylaxis in non-critically ill hospitalized patients that are not at high risk of ulcer formation and GI bleeding. So this one we should bring to your attention today. And the last but not least, PPI use of uncertain benefit means kita bagi pun tak tahu boleh berguna ke tak, which is PPI non-responsive GERD or extra digestive GERD symptoms. So you can see this paper actually has a very good classification of what is our what should be the consensus when we're talking about prescribing and using PPI therapy appropriately. So we talk about in ICU per se. I'm from ICU, that's why we have an ICU guideline that certifies the risk of stress ulcer prophylaxis in ICU settings. For those with high risk, if you are ventilated more than 48 hours, you're having coagulopathy, usually can be seen in sepsis patients, history of previous GI bleeding, CNS injury, where you can anticipate the recovery period could be longer, sepsis, vasopressin or inotrope use, which actually induce a lot of hemodynamic stress on the body. This is where stress ulcer prophylaxis is highly indicated and must be given. For those with moderate risk, you can consider giving SUP as well, chronic NSAID or aspirin use, high dose of prolonged steroids, like at least 250 mg per day of hydrochloric or equivalent, or ICU more than 10 days. So when we talk about yellow, means amaranth, yellow and red is considered okay. But those with low risk, like tolerating per oral diet or full gastric enteral feeding, and with no other risk that we can stratify about, we can worry about, then it is good for you to off the PPI per se in ICU settings. But little do we know that actually there's one clinical risk scoring system for nosocomial GI bleeding in non-ICU settings. When we talk about nosocomial GI bleeding, means patient has been in medical work for some time, then we give PPI, but we have to balance with the risk scoring system, which is Hershey's risk scoring system. So you can see here, there's an algorithm of using a risk factors with different weightage of points, and adding up that can actually tells you whether the risk is high or low, or medium low, medium high per se. Let's say the patient is aged more than 60, male, acute renal failure, liver disease, sepsis, prophylactic anticoagulation, and this actually each of them brings 2 points, while coagulopathy and maximum service means you're treating under medical discipline. I can say like this. This is what is being meant, if I'm not mistaken. It carries 3 points for each. So adding up this total risk scores can tell you if the 0 to 7 is low risk, 8 to 9 is low medium, 10 to 11 is medium high, and 12 and above is considered high risk for, and you should give PPI per se. So what does the current literature tell us about the prevalence on inappropriate use of PPI per se? So I'm quoting from papers that we have here in local and international settings as well. No offense, but just open for discussions. So this is one of the papers being published in our own country, from our own country. I think it's Pahang because it's a UIA. So proton pump inhibitors, they evaluate the prescribing of PPIs as stress ulcer prophylaxis for non-ICU patients in the Malaysian tertiary hospital per se. So they see that this is in Pahang. They review the medical database of patients in general medical wards from January to September 2019. Of 660 screened patients admitted to medical wards, there are 200 being prescribed PPIs as SUP. So oral pantoprazole is most frequently prescribed, which is similar to our situation here. But only 61, which is 30.5%, was prescribed according to the current recommendations, means the licensed use. Sex, age, number of medications, length of hospital stay, and receiving PPI were not significantly associated with appropriateness of PIPI prescribing. And also half the patient continued receiving PPIs at the discharge without even a documented indication. So this is something that actually should ring the bell among all of us here, and we try to ponder and try to rethink, are we doing the same thing? Another study conducted in Malaysian as well, also some considered recent study in these 2 years published. They found out actually that, I think this is in Hospital Serdang if I'm not mistaken, 46% was not indicated, and 32% was borderline indicated. You can see that there's a very clear distinction of categories here. Almost half is not indicated. So among those non-indicated PPIs prescription, you can see from here, there's an anemia with no GI bleeding, no apparent indication, NSAIDs for antiplatelet with less than 65 years old for very long term, I can say. Steroid, anticoagulant, biologics. Of course, we may sometimes these kind of studies, we may need to look into their methods and also the data collection per se on how distinctive in their roles to review the clinical condition of the patient. So, but this, at least based on the algorithms conducted in this study, 46% was not indicated per se. And we try to move out from Malaysia. We're going to Saudi Arabia per se. Okay. As we move into Saudi Arabia settings per se, so you can see that for those in non-ICU settings, AST means acid suppression therapy per se, means giving PPI or H2 antagonist per se. You can see a lot of them are actually inappropriate per se, with the Herzig clinical risk score of 7 and below, then 8 to 9. So this, when they have low or low medium risk in Herzig clinical score, it is not indicated for AST in this study. But 10 and above, they are considered appropriate. So you can see a large proportion of them falls under the left column of the bar chart. Another study conducted in Western countries about the improper use of PPI during admission or after discharge. So they actually track all the medication prescription up to that. And they found that actually half of them was inappropriate. You can see the numbers. It's almost half of that for the categories per se. Yep, another international study. I think this is from Singapore, if I'm not mistaken. Yes. Another recent study. You can see about the proportion of inappropriate use was quite high, and per se I can see. And this is a finding that actually I scrubbed through the when I looked through the evaluation of 24-hour gastric activity in patients' hepatic cirrhosis, because one of the common theories which is circulated among us was actually saying that if you have a liver cirrhosis per se, your risk of bleeding or GI complications in terms of bleeding or peptic ulcer could be higher because of the pH values per se. But mind you, when we talk about cirrhosis, and there was a previous very old study in 1996 where they tried to extract the gastric profiles of patients in healthy subjects and those with cirrhosis. They found that actually those with cirrhosis, which are in the bold line as you can see here, has actually generally a higher mean level of pH as compared with those healthy subjects. So what does it tell? When they have a 24-hour measurement and says that generally those are higher, that means supposedly their pH it should have even a lower risk to cause bleeding per se in this case. So actually that can actually help to clarify what are the actual clinical risks of having a bleeding. And we talk about pH profile per se in patients with liver cirrhosis. GI bleeding, I can say GI bleeding. So what is the aftermath of, after we have a very good research and review on the prevalence per se, what are the aftermaths that we are talking about here? I'm not trying to demonize PPI per se, but we are talking about if you are not using it judiciously per se. So if it is indicated, of course, it doesn't cause any problem. But when you talk about inappropriate use or non-judicious use per se, what are the aftermaths? Of course, this is quite debatable because some of the studies were measured in a very open label nature, and they might be confounded by many factors as well, like age or their underlying risk disease per se, which I did not deny in my discussion here. But of course, looking at the very bright side, there are still some findings that we can try to extract from it per se, and we try to evaluate or maybe make it ring a bell in our judgment later. So we'll talk about penny and cents. Penny and cents is something that being in concern among our hospital administrators per se. We talk about magnitude of economic impact of when inappropriate use of SUP on a non-ICU hospitalized patient. So you can see even in 2006, which is nearly 15 years ago, in America, this already cost 100,000 to 120,000 per annum. Okay, the cost of stress ulcer prophylaxis in non-ICU patients. That means we're contributing more towards that. I can not to say wastage, but medical burden or economic burden to our expenditures. We know that KKM is cutting a lot of budgets recently and so on and so forth. But this is something that we should ponder about. And this is something very technical. We will talk about lab data. We talk about pathology. This is about the proton pump inhibitors that affects the gut microbiome. There has been numerous studies saying that actually, if you give PPI for long-term without clear indications, one of the aftermaths is about gut bacterial translocation per se. So I tried to look into the research and papers, and we found that actually in this study in 2016, it does illustrate how the microbiome was being altered through the use of PPI. Okay, so a very complex diagram here, but never mind, we just have a look over here, the right column of significance of the study. Oral bacteria and potential pathogenic bacteria are increased in the gut microbiota of PPI users. On the population level, we see more microbiome alterations in the gut associated with PPI use than with antibiotics or other drugs usage. So I hope that this rings a bell among us. And up here is actually what is known with this subject. Is actually we know PPI use is increase in enteric infections and 65 increase in incidence of CDID infections per se. So we talk about SARS-CoV, oral vancomycin, but we can avoid them all if you know when to prescribe PPI per se. So this is something that we should actually consider, and maybe we can consult pathology department further about the insights. So the risk of Clostridium difficile infection correlated with the use of PPI was illustrated in another study in 2017 under World Journal of Gastroenterology. So they perform a systematic review and meta-analysis to indicate the rate of risk of CDID associated with PPI per se. So you can see, if we talk about odd ratio, means that the probability of this happening due to the use of NSAIDs, PPI per se, there's a skewed weightage over the right side rather than the left side. Left side means less, but 1 and above means that the propensity is higher. The risk of CAP per se. Okay, CAP is something very debatable despite the paper I show here. Some of them is saying that actually when you talk about CAP, you have to look at the population. So if you talk about the population, some of these populations like elderly, they might have inherent risk of having CAP per se, which might not be related to PPI. This is something that is being debated in the current medical field about these kind of papers per se. But let's take it as a reference for us as well. You can see. Of course, they even disclaim that actually there might be some other reasons for that. But at least they do show something actually, per se, the odds ratio here. But this is something that we can talk about, hypomagnesemia, which is well known, even was indicated in our literature and even our vaccine information per se, We talk about hypomagnesemia and PPI. So this is very common. So you see the weightage here with PPI use. And chronic liver disease, the risk of bacterial infection per se, some of the papers do indicate about that. But sometimes it could be very, very, how should I say? It's not easy to draw a conclusion from all these studies because some of them are observational per se. When they talk about observational studies, but in nature, it could be confounded by many factors. It's not like a randomized clinical trial per se. So the strength and power of the results could be a little bit vague in this case. But I'm taking all this as a reference of what are the strength of we'll call it propensity of research being done on the risk of using PPI per se. And risk of hepatic encephalopathy in SBP, again, is very debatable, but something that we can look into. And the risk of mortality per se. Okay, this is another kind of evaluation with a lot of probable or potential confounders from within. We're going to talk about PPI use when the patient also got bleeding. There might be others like conditions like sepsis that requires the use of PPI and intubated per se. So it's hard to draw conclusion, but we hope to ring a bell within when we consider our clinical judgment per se. And here's another study about PPI and the risk of DM. Little do we know that actually current literatures even dig into the risk of DM when it comes to the use of PPI. So in this study, which is conducted in American community by the nurses, if I'm not mistaken. Yeah, one of the nursing journals, if I'm not mistaken. So they try to have a very good evaluation on the use of PPI and the long-term risk of diabetes 2 mellitus, type 2 diabetes mellitus. So you see here, prospective analysis of 204,689 participants free of diabetes from 3 ongoing US cohorts. And this very large number, I can say. The regular use of PPI was associated with at least 24% increase of risk of diabetes, even after adjusting for putative risk factors. That means they try to settle the confounders per se, with a higher risk observed with longer duration of PPI use. If we say that the previous studies could be debatable, but how about this study per se with a very large number of we'll call it large number of cohorts in one study per se. It's not the meta-analysis, but one study per se. So hopefully we can actually, this is very new, actually about 28th September last year. Yes. So we'll talk about the aftermath of inappropriate use of PPI. So the next thing that we try to discuss is actually de-prescribing per se. Okay. De-prescribing is not a very popular term in medical field. It could be popular in certain areas, but not really being well known about that. But we talk about de-prescribing is basically in our daily practice as well. It means if you feel the medicine is not necessary, you can off it. This is what it means. Hold on now. So we talk about PPI de-prescribing algorithm. In Canada, they do have a study that talks about de-prescribing PPIs. So you can see from here, there's an algorithm for you to talk about. So when they are not indicated, or maybe when the risk is being lowered, then it's good to lower the dose, or you stop and use on demand. That means restart when there's a need. Monitor for 4 to 12 weeks, unless when there are Barrett's esophagus, chronic NSAIDs use with bleeding risk, severe esophagitis, or documented history of bleeding GI ulcer, then it's good to continue PPI. Otherwise, in this algorithm, it recommends us to actually look into the possibility of de-prescribing per se, and also use of non-drug approaches per se, like Gaviscon, Sucralfate, Gaviscon for OTC remedies. Another study even also have given a very relevant recommendations. So if the previous infographic is too complicated for you, then this is a simpler one. It's almost the same. Yeah, we'll talk about that. You can de-prescribe and stop and use on demand then you can look about it. So when we talk about interventions, if you are able to do proper interventions on stress ulcer prophylaxis management on inappropriate use in hospitalized patients in ICU per se. This is an ICU. The study actually conducted some intervention programs by pharmacists in the ward. Then they found that actually there's a very significant results can be found when we did some interventions on it. You see a very good inappropriate reduction in inappropriate rates and increase in the use appropriate in appropriate patients like indicated per se. So you can see we have even have markedly reduced the acid suppression therapy continuation upon transfer from ICU to general wards per se. So this is in general ward. You can see a very good reduction in cost per se. When we talk about penny and cents, this is how it looks. Thank you very much. I'm open to any questions, but before I conclude my talk, because I did give this talk in some other occasions among pharmacists in different settings per se. So one of the popular questions received from the floor is regarding the use of PPI among those like bedridden patients with NG tube feeding. We did have a discussion of consensus among geriatric pharmacists after that. So I'm going to bring up the plus point here. For those which actually have a very known pre-existing conditions, like previous UGIB, use of anticoag, then the use of PPI and the way of administrating the PPI is very important. So in those cases, when they have previous bad histories of that, then of course it is indicated per se. But in actual fact, we still need to actually evaluate the patient in a very sensible, we call it clinical sense. I think most of the bedridden patients with requiring NG tube, they might be somehow related to stroke risk. And with stroke, you might be using antithrombotic agents. You have long-term antithrombotic agents on board. And that could be actually something we need to ponder about. So as a whole, we still need to consider the clinical situation of patients. And one of the main points actually, the administration of PPI through NG tube. So what are the correct procedures when we're giving lansoprazole? If let's say we have an extemporaneous preparation of lansoprazole, we're giving pantoprazole, how do we actually give the tablets to our patients through NG tube? That was another issue that we talked about. But for that, nurses yang ada boleh personally contact dengan saya dan saya akan beri penerangan based on the clinical condition of patients. Basically, kalau kita tengok dari segi penyediaan untuk PPI dan cara kita bagi itu selalunya kena diselangkan dengan ubat lain. Then we have to flush to avoid absorption and so on. This is what we're talking about lah. Okay, is there any questions from the floor? I'll check YouTube here. Tak ada. Kebanyakan nurses di sini. Nurses ada masalah nak untuk bagi ubat. Untuk PPI dan sebagainya. Okay, tak ada lah. Okay, tak ada, kita end the broadcast today. Thank you.